So I too want to thank Sarah and Tammy for putting this satellite day together. I think it's really been wonderful to be part of it, and also to thank NIAAA for supporting this whole initiative, because I think it's really timely and also very important. I'm going to talk about neural and biobehavioral stress mechanisms. That'll be my lead in. What do we know about the neurobiology of stress? And why do we care about it in addiction? So I'll show you some data about why that's relevant in addiction. We've been clinically very interested. Can you hear me in the back? Do I have to? Yeah. Clinically, we are very interested in the phenomena of relapse, and so I'll talk about stress and relapse, and then coming back to predictors of relapse, and how we're using those as targets for change, for behavior change. So we know that stress and trauma actually is rampant in the US today. Rates of trauma exposure, I don't know if people know this, but are over 55%. All kinds of trauma, if you think about in the US. These are very high. Close to 43% report having 2 or more adverse childhood experiences. The CDC now is doing yearly behavioral risk surveillance, and these data are pretty dramatic in terms of people reporting on their adverse childhood experiences. The point being that it's important to bring that into your awareness as you're designing studies, because these things are, whoops, everybody's happy. More than half of US men and women have experienced psychological aggression by an intimate partner. And then, of course, there are the drug abuse statistics. 1 in 3 US adults are binge drinkers, 22% are still smoking. We heard great data on how many people are using cannabis, in the sense that you can't recruit alcohol-only folks, and of course, without alcohol, lots of cannabis abuse is going on. And we've heard about the opioid and prescription drug abuse. There's a reason why I'm talking about this under stress and trauma, and you'll hopefully hear about that in a minute. And then we've heard about anxiety disorders, and the lifetime prevalence of anxiety disorders is 1 in 3 US adults. So stress and trauma are very rampant. When we think about reward, we might think about, well, how is it that you and I can enjoy a drink and stop? Does it not activate our nucleus accumbens and our reward pathway? This is my big, you'll hear a theme that it is not the reward pathway that is the culprit. It is, as Dr. Martinez said, that there are changes going on in the striatal systems, particularly the downregulation. But these are all out there for us to enjoy, partake, maybe avoid our stressors and go into approach mode. So what is it that happens that goes out of control in terms of becoming addicted to something? And one of the things that we've done is we've really talked about this in a dimensional way, given that it's not necessarily some switch that happens at dependence, but rather that exposure to drugs of abuse, which are very active physiologically in terms of receptors, and we'll talk a little bit about that, starts to alter systems, clearly our motivational, emotional systems in the brain, and we move from this beautiful VTA, ventral striatum, subcortical, limbic striatal, and prefrontal balance to an altered alterations and disruptions in this emotional motivational circuitry, and we'll show some data on normal HB axis versus a move towards change in tone, autonomic and hypothalamic, and the case that in fact craving builds over time. And so I think we've suffered from the craving, literature has suffered from people sort of saying, oh, well, let me just show people this picture and see if there's craving. Well, no, there won't be craving, because craving needs to, is that desire or is that craving? Desire actually comes and goes, it's very transient. Craving, we've hypothesized and shown, actually lasts longer, becomes more of a physiologic need. And our challenge in research, this is what our patients tell us too, our challenge in research is, do we have the right methodology to provoke craving? And we've been doing a lot to struggle with that. We know it comes, it's tough to sort of categorize, but anyway, I'll come back to that. And the case we make here is that in fact, that the progression from light recreational use to binge drinking and dependence is really one where the recruitment of the stress pathways occurs, and stress disruptions then contribute to the disruption in what we call the behavioral control circuitry and the motivational circuitry in the brain. So that would involve the ventromedial prefrontal cortex and the anterior cingulate going all the way up to here, which we like to talk about the prefrontal control circuitry for stress, emotions, and desires. And under normal regulatory conditions, our stressors are being controlled by the prefrontal circuitry. You heard some nice, you saw some beautiful data on use of reappraisal and all kinds of cognitive coping, as well as people use behavioral coping to really modulate their emotions, their desires. Somebody's bothering you, we don't walk around slapping their face, something is stopping us. So there's cognitive strategies, but there's also behavioral strategies. And similarly, one can hypothesize that that circuitry would be important in controlling our cravings, so increasing self-control, decreasing craving, and perhaps losing control of that may be critical to the relapse process. So here's what would happen then under those conditions where you would lose this due to a number of different reasons, and we'll talk about that, and you might have this system of the amygdala, but also more importantly, our motivational circuitry going out of whack. So I'm going to start, like I said, talking about stress and what happens with stress. Now, you and I can get stressed today, right now, but we do carry our past stressors and how we've responded to it and our patterns of coping with it, with us. And so we've started to really look at this sort of from a lifespan perspective and cumulative stress and adversity. And we do a 20-minute structured interview called the Cumulative Stress Adversity Interview, which gives us different subscales, the major life events, the life traumas, the recent life events, and the chronic stress subscale. And what this tells us is through this we can quantify sort of somebody's stress load. How badly have you been hit in life? We all have had our adversities, right? So how badly have you been hit? And what is the hit that our brains have taken? Because our stress is affecting our brains. And so we quantify the number of these things happening, how often they've happened, the time period, etc. And then we also quantify recent life events. And the question initially when we started doing this was, does this matter? Does this predict behavior? Does it predict changes in the brain? And this last subscale has to do with the response to the stress, so the sense of being overwhelmed when you were in different types of stresses. And you can look at these quickly. I'm going to move, but essentially pretty major life events: abandonment, divorce, separation, losing a child, parental substance abuse, relationship difficulties. Life trauma includes all of the abuse, as well as violence, domestic violence, losing a home, things that have happened in the past year, similar things, but in the past year includes financial problems and things like that, as well as chronic stresses. Now, we're talking about all of this because there's very clear evidence that these types of really high adverse life events are major risk factors for the mental disorders as well as for addiction. And there's good sort of prospective data on that. I'm going to jump right into what did we see in the brain when you start to quantify this. We got interested in this because there's beautiful basic science data showing changes in the prefrontal circuitry and in neurons as a function of repeated stress. So for example, here's one neuron in the prefrontal cortex, very nice and healthy. There's the cell and the nice branches. And, whoops, oh no. And there's the stress-related neuronal atrophy, which essentially branches falling off, the synaptic retractions that occur, and things like that. So what would you expect in humans if this is in fact happening in animals with 3 weeks of exposure to stress compared to control animals? We obviously can't look at a single cell, but we can look at volume. When we heard some about volume being a really important measure. And so when we looked at 100 community adults between the ages of 18 and 50, and they were corrected for age and gender and other things, this is whole brain, gray matter volume analysis. The impact of cumulative adversity, this is really a correlation map. So what the yellow blobs are showing are just where the hot spot is. Where is it there in association? An association between higher cumulative adversity and lower brain volume. And it was specific. It was not all over the brain. It was in the prefrontal cortex, really curving right into the striatum and extending into the insula, but also into this ventral striatum, rostral areas, and then moving up into the ACC. And here's the association for the PFC region right there. So higher cumulative adversity experiences lower the volume. Now the chronic stress and the the negative emotionality, which psychologists have shown for a long time that as a trait measure that does modulate our ability to be in control and to manage stress, does play a role in this, and that seems to add, it's a good mediator of this relationship, but nonetheless, the events itself and load is associated with reductions in brain volume. These are data just in the interest of time. There was also an effect of cumulative adversity on the acute stress response. So we stress people in the scanner, and we wanted to know if cumulative adversity predicts your response to stress. And I'm showing you the high versus low in the sample, but we were able to do high versus low because there was this beautiful association between level of past load and your current response to an acute stressor, and the current response being in the amygdala hippocampus, greater activation during stress, a blunted response in the medial OFC, greater response in the striatum, particularly the dorsal striatum, the lateral PFC, and then when you look at the top third and the bottom third, we have this beautiful contrast. And this pattern then showed us in this paper, we've already reported, an association between the medial OFC and the hippocampus, and this sort of a negative association. And both of those regions were associated with physical and mental health symptoms. Again, in this community adult population sample that was not currently in any episode of psychiatric illness or did not have a history of addiction. So we're targeting this circuitry, which does include the striatal circuitry. So we are very much part of the motivational behavioral response circuitry. And so this was good. We became very obsessed with the idea of what is really happening when we cope. So you might be in the train and you had to get to a meeting and the train stops. And you have 10 minutes to get to this important interview. What do we all do? We're immediately coping. We're immediately figuring out what to do. And in fact, there are great individual differences in that context, right? Some people will start screaming. Somebody else might call someone. A third person might pull the red chain and jump out. I mean, there are all kinds of things to do. Somebody else might, my goodness, say, geez, maybe I need to accept what's happening. I can't really do anything. So we show all of our individual differences under that in that scenario, and yet I don't think we have very good idea about how does that really happen. We've had great studies around emotion regulation and cognitive coping, and that's really pointed to some things. But our question was, are there natural more neural circuitry that are separable and distinct that can give us a sense about neural mechanisms underlying stress resilience? And more importantly, is the dynamic activity going on during stress as we think about resilient coping. So we changed our approach to stress provocation, which previously had been using a individualized stress imagery paradigm for about the exposure time was 2.5 minutes. And I can talk more about it. It's based on Peter Lang, who's an anxiety, fear and anxiety researcher, and before he had come up with the IAPS, he used to use script emotional imagery paradigms. And a lot of the data I'll show you later will be about that. But anyway, here what we did was we actually stacked, we wanted to come up with a sustained stress provocation procedure so that we could look at what's happening in the brain as stress is just coming at you. And there is no demand for regulation, so that the brain has to start to regulate on its own or figure out what to do. And the way this works is that it's essentially a block design, stress versus neutral. In the stress, there's of course gray fixation or baseline, and then there are 6 runs, because we were also after getting cortisol and neuroendocrine activity. There are 6 runs, 60 seconds each, 10 pictures in each run, essentially mounting a sustained and provocation situation. Right? What it allows us to do, though, is to firstly see whether people are getting stressed, and in fact they were. Here are the 6 runs, R1 through R6, and you see this beautiful sustained stress response in subjective reporting. You see subjectively people reporting that they're feeling aroused. By the way, we have done this with Q pictures now, and we see the most beautiful craving response that is sustained. So we're very excited by that. In fact, we're using that. There is, of course, averaged very good heart rate. We had a pulse oximeter on, and people had elevated autonomic arousal and, of course, increased cortisol response. We had a condition main effect, as we would expect. There was definitely a stress response in the amygdala, in the hippocampus, in the striatal regions. You had the beautiful VmPFC and moving into OFC and moving into the ventromedial PFC downregulation, which has been documented that your PFC, certainly the ventral regions, start to go offline under stress. And so we saw that under stress conditions. Mobilization of the dorsal ACC and the SMA. When you contrast the stress versus neutral condition, you have much more of the limbic striatal activity, and this thing disappeared. So that was sort of interesting for us. We also wanted to see what happens with cortisol, because we had a mobilization of cortisol. Well, cortisol signaling should be there also within in the brain, and we have these really nice associations in cortisol, both with the amygdala hippocampal regions right there, with the hypothalamus, which was activated in the previous condition, but also with the ventral striatum, and this beautiful down negative association with the VmPFC, which I showed you earlier in the stress condition. So we have nice whole brain correlation with cortisol, and then we had very nice condition by time point, so dynamic effects of stress. And what we see here is that some regions are going down in the stress minus neutral, right here, the insula, the ventrolateral PFC, but there is also a circuitry that's mobilizing over time. Okay, so this is from late minus early. So towards the end of the so the last one, I'll show you time courses in a minute. What we see is the ventromedial PFC and the ventral striatum are mobilizing. So what we think is going on is that we're actually picking up on 3 different separable networks, patterns of response. One is, we'll start down here, is a sustained circuitry. So stress is coming at you, and there's a circuitry that's the alerting, the stress circuitry that's saying this is not good, and that's the amygdala and the hypothalamus, also a part of the right the left hippocampus, both bilateral hippocampus, and certain parts of the insula. But there are 2 other parts going on. One is this decrease, so things that were increased before. Let me see if I can point this out. The ventrolateral PFC, the insula, but they start to go down over time. So there's some adaptation, there's some sort of decrease, a natural sort of sense of wanting to reduce the experience of distress. And then there's this third thing happening, which is this mobilization of responding, which we like to think about as your behavioral control network, the idea of the regions of the brain that are actually involved in mobilizing to do something about the stress. And this is where things get complicated, because you could do something good or you could do something bad, right? But nonetheless, the ventromedial PFC and the ventral striatum are mobilizing towards action. And you see this really beautiful sort of change or coming back online, so to speak, of the VmPFC. The ventral striatum wasn't much different, but you start to see it mobilizing along with the VmPFC and this decrease. And so then what we wanted to really think about was, well, does the VmPFC really hold any cards for behavioral control? What we found was that actually that change, or the dynamic activity or the flexible response of the VmPFC, was in fact correlated with active coping scores that the subjects had told us about. These are all healthy, non-addicted individuals. But also those who were not, luckily we had good individual variation in the sample of 30 individuals. Those who were not able to mobilize the signal of increase over time, those people had higher scores on emotional eating. They then tended to be binge users of alcohol, and there were also those who were not great at emotional regulation. So they reported that they would get into fights and arguments more. So clearly this sort of gives us a hint that perhaps the VmPFC and its circuitry is involved in increasing behavioral control and mobilizing for adaptive coping. Now, what, in the interest of time, I'm not showing you, but is in the paper, is that we seeded this region to look at, is it talking to any of the other regions, particularly the ones that you were hearing about earlier. And in fact, this region, from a stress minus neutral functional connectivity analysis, actually very nicely increases connectivity with the DLPFC anterior as the anterior parts of the frontal region on the left side, as well as the IPL. So that's really nice, because those are regions obviously involved in working memory, in cognitive control, and in executive attention. So let me move gears now and say, how does this really impact and why did we go down that road to understand stress neurobiology a little bit more in detail? Well, we are interested in that because we think that actually stress dysfunction has a critical role to play in relapse. What you're seeing here is data from a substance abuse treatment clinic, 878 patients in 1 year, and this is time to discharge recorded over 1 year, and this is proportion who survived or who maintained their good treatment outcome or treatment abstinence. And of course, we're not doing very well with cocaine and marijuana. There are no medications. And so you see even by 120 days, people are way below 50%. With alcohol, we have good medications, or somewhat good to at least get people started off, as we do with opiates, but even there you start to see things falling off. In the interest of time, I'm going to show you data only from our alcohol studies. Maybe there are a couple of slides with cocaine studies. But essentially our model has been that if relapse is happening in the face of stressors, in the face of drug itself, being exposed to drugs, being exposed to cues like your favorite bar, we should have a readout, right? We should have measures that tell us what happens to people under those conditions. And there are all these other changes that are going on as a function of the actual exposure to high levels of drug. And perhaps those readouts will tell us something, will predict craving and relapse. So we do need to give a nod, and I want to really highlight this, that these substances of abuse are direct activators of the stress axis. They modulate the autonomic, the HPA, the stress hormone axis, as well as now we're learning about the immune axis. There are direct effects as well as indirect effects. So that's what's stated here. It's not just alcohol. We know nicotine does this, cocaine does this. With chronic alcohol, there's desensitization of the HPA axis, there's blunted response to stress, but there's an increase in tone. I'll show you some of that. There's decreased ability to regulate, of course, and fear potentiated startle, for example, is blunted as well. So there's lots of adaptations, and this is what the challenge is when you're coming into treatment, right? With individual variation, there are these kinds of changes to our biology, our stress biology, and this is what we're up against when you're trying to teach people about coping skills or going out and facing the world in terms of negotiating coping with drug cues, coping with stressors. So I'm going to show you some data on inpatient studies where people, treatment-seeking folks went into an inpatient treatment setting. They were exposed to a laboratory experiment, also neuroimaging, and then we prospectively followed people. They were referred, of course, to aftercare after inpatient treatment. We followed them with multiple face-to-face interviews to see how they were doing. And during the laboratory challenges, they were exposed to a stress, cue, neutral relaxing situation. So there were 3 experimental conditions on 3 separate days based on personalized guided imagery. All of this has been published quite a bit, so if you have questions, I'm happy to answer them. Across drugs of abuse, what we show is that even with 5 minutes imagery exposure to your favorite stressor or to your most important stressor or to your favorite cue, compared to neutral relaxing stressor, our patients show a much greater response to craving, in terms of craving, stress-induced craving, as well as cue-induced craving. We also see this with anxiety, which I'm not going to show you in the interest of time. And here's data just from the cocaine craving. Stress-induced cocaine craving and cue-induced cocaine craving prospectively predicts time to relapse, meaning what? That in the laboratory, if you have an increased high craving response, you're going to relapse more quickly compared to those who had more smaller craving response, and that's sort of the spread of the predictor variable in terms of predicting future outcome. What we know is that even this is from patients who are 3 to 4 weeks abstinent. AD is alcohol-dependent patients, coke is cocaine-dependent patients. Beat by beat heart rate, and this will be consistent with what you heard earlier from Dr. Bates, is that they have higher tonic levels, okay? So there remains a sympathetic or autonomic upregulation in the body. There also remains an autonomic HPA upregulation in terms of basal state. And what we find, in fact, is that the CORT-ACTH ratio, so higher CORT levels responding, higher CORT for a given level of ACTH, greater the adrenal sensitivity for that CORT response, and this is basal CORT response. So again, that tonic change is actually better at predicting relapse than the blunted response that we get in terms of experimentally inducing stress. Once again, higher court ACTH response, more quickly people relapse. That's right over here, that ratio, compared to those who don't have that level of adrenal sensitivity. And the spread is quite a bit. This is sort of, about 10% still surviving or still abstinent compared to about 50%, right, on day 40. So a month after discharge. So now you're 2 months into recovery. So that told us that this was important. In each of these models and curves that I'm going to show you, there was a question earlier, does neurobiology, or there was a comment earlier, does neuroimaging really translate? Is there going to be utility? Does it tell us more beyond what we know from self-report measures in history and clinical history? This is after accounting for history of severity of drug abuse, age, any other kinds of changes. In 4-week abstinent alcohol-dependent patients, what happens in the scanner? So we see, of course, in the provocation of stress, Q and neutral, an increase in anxiety response. The Q condition is more anxious. We've talked about this in our papers. Of course, we have a beautiful increase in craving response during those stress and Q trials in the patients, shown here in blue. And the question was, what's happening in the brain? Whoops. Here's the heart rate response, and this is for Dr. Bates to show her this basal, again, beat by beat, basal heart rate was upregulated in 4 weeks abstinent patients, and then this sort of blunted response to stress and to cues. What happens in the brain? Well, we have this beautiful interaction difference between the patients versus matched controls, and one of the hot spots is, a critical hot spot is the ventromedial PFC. And what's happening, if you look at that ROI beta weights of that region of interest, what we see is that the healthy controls under a neutral relaxing situation, like sitting and imagining being at their most favorite relaxing thing, watching the waves at the beach, it had to be things that were quiet and singular, not arousing. They deactivate that region beautifully, whereas our patients at 4 weeks of abstinence have higher levels of activity in the ventromedial PFC. And in fact, it sort of goes down into the ventral striatum if you look at that. So in the neutral condition, you have the biggest dramatic change between the groups. But then you see the relative change here, where there's the the controls are showing a very nice mobilization of the ventromedial PFC, like I showed with community adults in our resilience data, that they in fact were able to mobilize the ventromedial PFC, and our patients are not. You have deactivation under stress and arousal conditions. In fact, you see this as if the brain in this region is just kind of petered out. It cannot really sort out the difference between those cues coming at them. Self-report, they're telling us that they're more relaxed in the relaxed condition, but the brain is not, it's lost its flexibility. I think you heard some of that earlier, this ability to be flexible and respond to new and different cues and then regain control perhaps may not be there. So does that matter when you pull out the ROI of that? In fact, the neutral state upregulation or hyperactivity in the neutral state predicts craving under stress, that beautiful high levels of craving I showed you, cravings under Q condition, so does the ventral striatum, and so does that precuneus region. These are all the regions that remained hyperactive during a relaxed state, even at 4 weeks of abstinence, and those regions are actually associated with what happens under stress in the craving condition, but also an inability for the circuitry to get mobilized under stress or arousal conditions. Does that matter? It absolutely matters. It predicts relapse, not just stress-related relapse, any relapse. And you see these curves, these are relapse curves that start to spread out. So the brain is giving us more power in terms of being a more sensitive predictor. Again, after correction of severity of history of alcohol abuse and any other measures that may be predicting outcome, what we see is that hyperactivity in the neutral state, neutral relaxed state, predicts by day 30, basically those who had the most hyperactivity had completely relapsed, whereas those who had not, who were able to downregulate during the neutral relaxed state, this is pretty high at 80, 70%. So we are picking up on this critical individual difference measures of why some people relapse and others don't, and here seems there is a signal that is predicting that behavior. And similarly then, the inability to mount a stress response in the ventromedial PFC and increase activation of that also predicts a shorter time to relapse. And using a completely different outcome measure, like days of drinking in that follow-up period, in the prospective 90-day period, we see in a whole brain correlation that actually the number of days of alcohol used was associated with that ventromedial PFC rostral ACC activity in the stress condition and the hyperactivity in the neutral condition right there. And in addition, blunted insula response, as well as more extensively the neutral, the striatal regions were in the neutral condition were also predicting outcomes. So we think that we are actually beginning to really come up with a relapse phenotype which is relevant for clinical treatment, I think, sort of as predictors of what to target. So the biobehavioral neural response, I didn't show you volume data in the interest of time, but this is already published. We have a smaller gray matter volume in the medial frontal and posterior precuneus and IPL regions that predict relapse. I showed you stress and cue-induced craving. We have serum BDNF data that's interesting at predicting relapse. I showed you the HPA axis. And then this hyperactive striatal VmPFC at basal, relaxed neutral states, and hypofrontal stress arousal associated with craving and relapse. So we think that we're sort of beginning to at least identify some predictors that maybe we can start to look at as targets. These do overlap with the stress circuitry that I talked about, particularly the VmPFC as sort of a key node in the behavioral control circuitry, as is the ventral striatum. And now we're sort of focusing on the types of interventions that would actually change or that would have an impact on outcome and target these changes as mediators for mediating outcome. So I'm just going to show you 2 or 3 slides using only the pharmacological target. We are doing things with the behavioral strategies, but in the interest of time, and those are not published anyway right now, I'm going to show you data with pharmacologic targets. And so in terms of pharmacologic targets, our first foray into this has been with targets that are repurposing targets, so and things that our colleague Amy Arnston at Yale, who's a prefrontal cortex neurobiologist and monkey physiologist who has identified what happens to the prefrontal cortex under chronic levels of stress and how can you rescue it, how can you bring that back. And what she's shown is that the alpha-2 adrenergic agonists like guanfacine, lofexidine, clonidine, although these are different somewhat in terms of their receptors, these will decrease the level of brain norepinephrine. And by doing that, it decreases what's happening in the prefrontal cortex in terms of being flooded under stress. And there might be a sense then in the moment to have better control or better access to those control regions. Prazosin is both of these have been blood pressure medications. Prazosin particularly has been a blood pressure medication. It's an alpha-1 antagonist and also shown in her signaling pathway in the prefrontal cortex, protects those prefrontal cortical neurons. So we did a study, 2 different studies, one in cocaine craving, a series of papers there, and then with Sherry McKee looking at tobacco, randomized people to guanfacine 3 milligrams a day versus placebo, double-blind study, tested them in stress versus neutral imagery, and you see that the number of cigarettes smoked in an ad-lib smoking was lower in the guanfacine group under stress conditions. Same thing here in terms of reducing stress-induced craving. In the cocaine craving, we seem to have a interesting sex difference where guanfacine decreased craving and anxiety in the females, but not in the men, and we have some ideas and thoughts about that, but clearly some sex-specific effect of guanfacine. We then looked also in the brain, and during the Stroop task. I think does everyone here know what the Stroop task is? Okay, good. What we see here, and this has been recently published, that in the incongruent, particularly in the incongruent trials, the ventromedial PFC under guanfacine stays up. So again, you have this region of the brain sort of perhaps staying in control longer, as well as the dorsal cingulate, as well as the insula and the SMA region. So guanfacine seems to be bringing back some of these cognitive control, working memory, as well as decision-making circuitry. perhaps really bringing back cognitive flexibility, which was what we were targeting. With prazosin, I'm not going to review this. This is again Amy Arnston's work with prazosin, really looking at working memory tasks, and prazosin helping with working memory. What we've shown with prazosin is that actually it decreases craving right here. Under, again, prazosin group here, 3 weeks of 16 milligrams of prazosin versus placebo. In the laboratory task we have, stress-induced craving in the placebo group and cue-induced craving, but prazosin decreasing that. And then very small numbers of people, but really showing that with prazosin compared to placebo, we have an increase in the PFC response under drug cue conditions and under stress conditions. So this is unpublished. This is still small samples. We are collecting new samples. Based on these data, we actually have a phase 2 trial from NIAAA looking at efficacy of prazosin for alcohol dependence, but we also are now imaging people as well as doing multi-method imaging, so looking at cortisol in the scanner as well as looking at the brain response to see if we can correct and fix that disrupted ventromedial PFC ventral striatal circuitry that I showed you that's affected by chronic alcohol in early abstinence, and see if that mediates treatment outcome, because relapse rates are high. So if, of course, some people are not going to respond to the medication, but those who are responding, could it be through this prefrontal modulation of the circuitry as Amy and others have predicted. So in conclusion, I think we've sort of taken a step back in terms of treatment development and thinking about, can we strengthen the stress resilience mechanisms, or the ways to sort of bring back control as opposed to slapping down craving and regaining control over craving. Can we think about increasing self-control that might also have downstream effects on craving? But more importantly, what we're really interested in is thinking about alternative preventive approaches. It's really hard when you're working with addiction to see what addiction, the whole process of addiction, does to people. And we're just not in a healthcare system that has realized its potential in terms of prevention. I think in psychology and mental health, we are really in a place where we can be thinking about stress resilience strategies. And so the idea would be to really think about building cognitive and emotion regulation, increasing behavioral control under stress conditions. Can we target even prior to people developing mental illness, or having maybe even one episode or being at risk for it, but not having chronic mental illness, to break the connection to maladaptive coping and poor control by pharmacological interventions, but clearly also behavioral interventions, as you heard, with CBT and mindfulness. And we're also very interested in social public health interventions. So with that, I want to thank everybody who does the work. Don Jusia, who is first author on the imaging alcohol paper that is predicting relapse, and she has a beautiful K now actually that crosses very nicely with what Dr. Bates was talking about, as well as others who've been doing Sherry McKee's data with guanfacine, and a number of other people who've been doing the work, as well as NIAAA and NIH for funding this. Thank you for your attention.